might have to split those three up. Good morning, everybody, and welcome to the board meeting in the public on the 7th of July. So you're doing it really. So I want Marsha. That's still chief. I'm very good at on going on the words. So welcome, very good to be here. And Alan Morris, yes. Mark, sorry. Mark, so sorry, I'll get there in the end. Our new Deputy Chief Finance Officer, so welcome, very good to be at the meeting. Just been online to see this. And welcome to James. And is our new coup, as this is his first public. I've got apologies from Mark Bassalian, Med, and from Jonathan Dunk, who is at a finance officers conference today. The Hoskins, who is as of Marshall, is advertising. Apologies. Got declarations of interest. Are there any new interests to declare? Or any interest in relation to items on the agenda? And I'll just remind people that the register of interests is a live document and always update it at any time. We've got quite a lot on the agenda today, but I think really, first, key headings are going to be around patient safety, patient experience, and performance. There are things we need to look at, obviously, on the rest of the items, and particularly in people contribute the residents' results. But I'm kind of going to be exact if there's anything else further down the agenda until we get enough time, because the items are limited for quite short slots. So I think we'll just make sure we give ourselves enough time in front of the agenda and then move through those that we can just take from noticing. If everyone's happy with that, then I think Marshall will start with the patient story.
Yes. I'll give a little outline and then we'll get right in. This story particulates about a lady having access to research, having been diagnosed with breast cancer. And she started out with the personalized breast cancer program. So she was invited into that trial following her diagnosis. So she came in and she was diagnosed. So she was approached by the breast surgeon when she was diagnosed. And having gone through that program, they realized that they have the gene. So her daughter, who was diagnosed with breast cancer prior to that, has also changed the management of what she had thought of. So got both mother and daughter outside, but also the head of research should you need further context on the research program. Yeah. Thank you.
Hello.
Morning.
Thank you. Welcome. That was one. Morning. Actually, do you want to introduce, and then I'll introduce us.
Yes.
I'll go around with the back and introduce.
So this is Jean.
That's Jean. Yeah.
Rebecca.
Who's got it?
And Tina.
See you. So thank you very much for coming to share your story with us. I'm Lady Travis, I'm the chair of the trust. I won't introduce everybody by name because otherwise that would take up half the time. But if anybody wants to ask you a question afterwards, they'll introduce themselves before they do that. But we're really grateful for you coming here to such a big forum of peace. They are all very friendly. So thank you. So Varsha, I'll leave you your hands to go through it.
So Jean, I've provided a little bit to outline as to how you got invited into the study, but I'm going to hand you the story of it. This is yourself to tell.
Yeah, well, I think it was 23rd of June last year. I was invited for a mammogram. I was 71, so I thought they must have forgot to do me just before 70. I'll go on a bit done anyway. Never giving it a thought there might be anything, because 2 years previous, Deborah had cancer, breast cancer. So 3 days later, I get a phone call saying that they'd found something and could I come to the breast clinic that Friday. And we were laughing, going, lightning doesn't strike twice, but it did. It was breast cancer, exactly the same type that Deborah had. And then I can't just remember where which appointment Becky turned up, but she asked me would I be interested in taking part in the clinical trial. I said, absolutely. I said, because there's got to be something genetic going on here between the two of us, you know. So I said yes. And when I had to have blood tests done, they did extra blood tests. All I needed was extra blood tests. And when they did the biopsy, when they did the lumpectomy, they wanted part of the tumour to test. And then it came back that I had a genetic mutation. So Deborah is just waiting now. She's had a blood test and everything, but the results haven't come through. But since I've had my breast cancer, Deborah was on tamoxifen, but she was still having periods. So she went to see her oncologist, and they found thickening of her uterus. And they said, oh, but it's nothing to worry about. But Deborah said, my mum has been tested positive for this genetic gene. Right, we'll look into it. They found precancerous cells. So Deborah had a full hysterectomy, but because they found it precancerous, she didn't need to have chemotherapy or radiotherapy. But if I hadn't had that trial, we would not have known, and Deborah would have ended up with full-blown of uterine cancer, and it would have been a different story. So I just think it's so important to get it out there, and I just wish more people could take part in these trials, because only going back through my family history after, I realised my mum had 5 sisters, and she was the only one that didn't die of cancer. All her sisters, and 2 of them had breast cancer. So it's like people really need to know, and to be prepared for it. I mean, I've had chemo, I've had a lumpectomy, I've had chemo. Mine was stage 3, it had gone into my lymph node. That's why I had to have chemo. I've just finished radiotherapy. I'm going to be going on to I call them chemo drugs for 3 years, but I also have to have a lumpectomy and have my ovaries removed as a precaution. I'm going for that because I want that as a precaution. Deborah's already had a single mastectomy, and if she tests positive, she's having her other breast removed as well. And she's already had a hysterectomy, and they've taken the ovaries, so we'll both be doing as much as we possibly can to stop it coming back. So, yeah, I just think it's just so vitally important that everybody out there knows about these trials and can take part in them. It's absolutely nothing. You're having a blood test anyway. You just give it a little bit of extra blood. You don't know that you're donating some of your tumor because you're having an operation anyway.
Yeah.
So it's like it's no hassle whatsoever. It's just so easy to do. Yeah, but I just think it's so very important. And I think it's saved Deborah as well because I've had it done.
It's so great to be taught in a public meeting in public, but need to hear and see recorded that positivity about what it meant in the process. So I mean that's amazing to hear. I didn't know whether anybody else was planning on saying anything.
You summed it up very well. So the studies run through Cambridge, so it's sponsored with the University of Cambridge, and they're looking at whole genomic sequencing. So looking at people's genetic makeup. And as Jean said, we collected some blood samples from her and some tissue, and we went through her family history, and they did the whole analysis. And then once they've done that, they gave us a report detailing if there was any germline inherited changes. In Jean's case, there was, and that went back to the breast consultant who initiated a referral to Oxford Genetics, so that part can take place. But also we get other information. So, following surgery, some patients go on to have chemotherapy. So it highlights, this chemotherapy might be more, better in this person's case compared to this one. Any clinical trials that are going on at the moment, looking at like targeted, sort of like immunotherapy treatments, this person might be eligible for this. Any side effects that they might have to certain treatments. So although, the genetic part is very important, it's also giving clinicians information about, ongoing treatment that in a more sort of personalised approach. It's not like a one size fits all. It's like, actually, we've done this and we found that this may work better for this person. So, yeah, it's really an opportunity.
I think they would like to ask Hannah.
First of all, thank you very much for coming. As I think it's really brave of you to come and have a conversation with us in such a public forum for the both of you. There's an awful lot that's happened to you that you can tell us. So first and foremost, thank you very much. What I was wondering it is of the number of people that have breast cancer, what's the percent that have a genetic mutation?
So we have recruited 38 patients onto the study. I believe we've had 3 or 4 that have come back with genetic mutations. But we're still working our way through the reports. So sort of monthly, we have these meetings with Cambridge where they give us the findings. So we still got information to the application. So the form.
Obviously, you'll then follow the family.
I think you're very young. You mentioned the studies. Association is an organization which just starting to break into this area. So I think it's very early because it's not a couple of years in actually doing something. This organization is very join the small post-COVID things that we
You might need to speak up a little bit. It's not carrying the air conditioning stuff. So.
I said we're very young at the beginning of the journey in genetics and genomics research, and we actually already approaching post-COVID. We haven't had any studies trying that, so it's quite early stages for us. And also because it's about 2 years, and we actually get more figures and an accurate percentage of the cases.
You said at the start, when you got offered, you said, yes, I was definitely going to do it. And that was obviously before you really knew what the journey was.
Yes.
Why were you so? Because it's fantastic. It was great to hear. And
because I honestly thought once when they said a clinical trial for genetic mutation, and because Deborah had it, and I thought absolutely, I want to know. I really want to know because it doesn't just affect me and them. Deborah has 2 sons. My son has 2 sons. It can affect them it can affect them with prostate cancer. But also, if they come to have children, if they're carrying the gene, their daughters could end up with breast cancer. And it's just that knowing.
I love to hear, as a woman, I love to hear the kind of bravery and confidence of sharing a really difficult journey and story. And I think women are often very good at being in that space of saying, this is what's happening to me, this is what's being removed, this is what I haven't got anymore, this is what I went through. And you're a absolutely brilliant example of someone able to sit and talk like that. So I think it's great to be. Thank you. Ian.
Hi there, Ian. I'm
Hi.
Ian's Chief Medical Officer. So for me, it was that bit there really, in terms of the genetic study. Actually, the consequences of you participating might actually be stronger for Deborah than they were for you. Consequences maybe for Deborah's children, nieces, nephews, etc. In terms of the consent process and understanding what you were getting into and what the risks and benefits were, was Deborah brought into that discussion, or was it a conversation between Rebecca and yourself?
I did mention to Rebecca, when Rebecca asked me would I like to take part, I did mention, I said yes, and I actually said because my daughter's had breast cancer 2 years previous. I said, and there must be some connection, there must be something going on. And that's when I said, yeah, I want to do it, I want to know.
It's clear Deborah is supportive of you participating. Conscious there are some other diseases, Huntington's disease is one of them, where quite often children of people with Huntington's don't. It's a fascinating area. You've navigated very much.
I absolutely did want to know.
Oh, of course, yeah, absolutely.
If the test had been offered to me when I was diagnosed, I absolutely would have gone ahead as well. Because of the impact on my boys and future grandchildren. Both of my boys have been incredibly positive about it as well and want to be tested. So there's no concern from them about it. I mean, they want to be empowered to know and to make decisions for them.
And my son's waiting to be tested as well.
Yeah.
Yeah, he's waiting to be tested. Because he has 2 sons, then again, if he tests positive, they may carry it as well, and in the future. So it just that knowing, isn't it?
So I'm losing, I'm not seeing more hands, but I can just tell you, carry on.
Hi, Gina. It's a brilliant story. Thank you so much. It's quite clear you're a really positive advocate of yourself and your family, which is super. Maybe it's not a question for yourself, but I was just curious as to what the trigger was for you being offered the trial, given that you had a family history, and what prompted you to be offered the trial.
So when we opened studies in the hospital, all the breast surgeons were involved. So one of the breast surgeons was actually leading as PI on the study. And obviously in the regular MDTs, we have about all the patients that are coming through breast care unit. As part of the study, we have an eligibility criteria. So actually for this study, anybody that had been diagnosed with breast cancer could take part. So I think it's one of the breast surgeons decidedly said, I've got this lady, I think, I'm happy to offer it to her and see what she thinks. And so that's how we found Jean, was just through our MDT and,
And to what extent does the family history part play in the decision making process, was really where it was coming from?
So it doesn't to a degree, because everybody can take part. But as part of the registration process for the study, we look at family history because that information is important to the researchers when they're looking at samples and that sort of thing. Trying to sort of correlate things to what they found, look at family history, does this make sense, that sort of thing. But anybody can take part in the study. If they have family history or if they don't, we've had people come through that are adopted but don't know anything about their family history. So actually, that information is interesting to them. It's their sort of nothing to go off to start with. So it's
And the family history only comes into it after all the after the blood tests and the tumour. That only comes into it after, doesn't it?
It was very good. Thank you both. I'm Ganesh, one of the non-executive directors. I suppose what would you suggest we do best? Sort of advertise to find out through your organisation and the NHS do help research to encourage more patients to look at it. I guess probably a separate conversation or community.
I would have loved to be given an opportunity, back to when I was diagnosed, being able to take part in something like this. I think, I mean, I suppose it depends whether a trial's actually running, whether you're actually going to get the opportunity to take part. So for me, it would be trying to make the opportunity more widespread for more people that have been diagnosed. Because it's life changing to have that level of information. But I can't help but feel that if I'd been diagnosed with this earlier, you would have been able to get away with less invasive treatment. If you were potentially going to be diagnosed sooner, I managed to avoid chemotherapy because I was diagnosed so early. That's just luck. I found a lump, so I found it earlier than Mum did. I did feel that I could have helped her if I'd been able to get the diagnosis sooner.
So I'm going to try and move this on. Okay. So I'm going to say thank you very much, in particular to you for coming and sharing so openly. It's right. It's very powerful, and you speak particularly powerfully and openly about what is obviously a very difficult time. And I think that it will benefit more people. So women, so thank you for good research.
Thank you.
Us.
You're more than welcome.
Thank you very much.
Thank you.
I think I know Marsha's out, but I think we'll be all right to move on to the minutes. So the minutes of last night's meeting, is there anything anybody wants to amend? Or is there anything anybody thinks is missing from the minutes? See any plans up? So we're going to take minutes as approved. And then I think there are two items on the action log. One of them which is going to be coming back here in September around the anti-wasting programme, 6-month update. Very quickly, Catherine. And the agenda items are kind of an ongoing discussion. And I think we'll be an ongoing discussions put forward today, both here and in private, around the integrated performance report. And to be able to kind of make sure we're having really good conversations around it. So I think that's part of today's conversation and ongoing. Anybody think there's anything missing from the action log? So I should move us on, which basically moves us on to leave. So the first reports in there, in the report, obviously acknowledge the report. Joe, I think comment on it, but obviously we take his findings very seriously and are firmly committed to safe and transparent and accountable and listen to women and their families. So I think we're committed to that. And I would just like again to say thank you to colleagues across to continue to work so incredibly hard in obviously last week what was very difficult conditions. So thank the exec team, as I did it extraordinary role, for supporting bodies and also for themselves continuing to push really hard and make sure we're doing everything we can to do. Including, I think, 2,000 isolates. I think it's 2,000. We got to get where we managed to find 2,000 isolates at short notice, but good. I wasn't really going to pull anything else out particularly from here this month, unless there was anything anybody wanted to ask about. If not, I do have a move us on from 9 and hand over to Joe.
Thank you very much, Chair. I will take the report as read. I will ask Ian, and quite a few of the things come up in the overall board agendas anyway. I have two things. One is I'll pass over to Ian in a moment just to give the sort of latest on the NHSE service response to Tom services reports. But I just want to publicly thank the friends of MK Nesbitt shop has now closed, and we did host a celebration for them before they left, and building works have already started, making sure that we develop the main restaurant area. But if I can pass over to Ian for the latest response.
Thank you. So the Auckland report into Nottingham was published last week, and then Marinus Amos's rapid review of 10 trusts across the hospital, across the country, including our local tertiary hospital, was published Tuesday. Tuesday afternoon, medical director CNOs from across the country were summoned to a meeting in London, where we heard a little bit about those reports, but also about responses. And I think the positive thing about that session is we were able to hear directly from our team chief executive at Nottingham, so Joe Williams, who is a relatively new chief executive at SAN, which shows with Telford. Maternity journal there too. They spoke very frequently, pushing around those discussions. In essence, in relation to both reports, there was a lot of discussion about the Nottingham team. Thousands of actions and action plans like passing those as the others action plans was calls to arms around a 100-day fertility and neonatal sprint, 10 particular actions that the HSC and HSA will to see progress and possible organisations and won't go into more of them, but they include growing out markers with maternity and being very clear about dual board over accountability of medical directors and achievements rather than siloed approach that well addressing inequalities, start listening, exercises, and diagrams, payments, and to specific about delivering safe and triage in essential services, the various triage tools available, so ready to start in certain stations. Those definitely specifically following so those are the sorts of things in this 100-day sprint was.
So, thanks, Ian. And I just wonder about you and Marcia, what, as you know, I chair the maternity insurance group. What do you think are key risks? I know I'm preempting the 100-day sprint, but what do you think at the moment, from your knowledge of our services, are top risks are?
So we'll obviously come on to that in more objective where we get to the maternity and groups thoughts. But I think we can't be complacent about culture. So relationships with obstetricians, midwives, anaesthetists, patients, birth partners, it's really complicated. It's in every organisation, and we therefore shouldn't be complacent. It needs to be working in that area, as does every organisation. I think our physical estate is a concern both in terms of the number of beds, which is due to expand in the coming weeks, but also the position of those beds. That's why we're building a new hospital estate in both maternity are maintained as good a state as they have been in sort of certain which
Income starting with just, I know it's obviously this week, when 100 days timeline for some of this coming back to either maternity insurance group. When do you think you'll know that that's going to look like? I'm not asking you what that is right now, but
so I think one of the very important things, I think, you want to have to read a little bit between the lines as to why medical directors and nursing directors are taking responsibility in June May. We'll have to talk about the maternity insurance regulation on this month, but it is going to be really important that yourself, you and the whole executive team take ownership of this plan rather than generating just so expensive. So I'm sure we'll be discussing every maternity group. Just in the year aspect, I'm sure we should get something about it.
so that's that would be 2 the 100.
Yes.
Yes.
So we could escalate race from
I think that might be helpful. I think that might be good to note that that's how we approach it, so that we don't find ourselves in September, 60 days into the 100 days, having the first conversation. I think it would be helpful to know the board can get assurance by knowing it's going to be lifted to the maternity insurance group in a shorter time. Anything anybody else wants to ask? I'll come back to you, Joe.
That's something you'll find.
Thank you very much. So I shall move us on to patient safety. Meeting, I think. Okay.
Yes, thank you. Hopefully you can hear me okay.
Also, she looked very doubtful, Kate, but it's obviously because we were looking for the mute button. So yes, I'm definitely happy to hear it.
Looking for the mute button, and the audio in the room isn't very good for those of us on screen. So I think there's probably a bit of a delay actually. But hopefully you can hear me okay, and Ian may come in as well on this report or others. The patient safety report is quite a lengthy report. It's gone first to quality committee as well as through the executive branch of the organisation. The report details, it gives quite a lot of detail about incidents in terms of the timeliness of investigation and closing of actions, and a good overview of incidents that are currently ongoing and being investigated. Mentioned obviously the Ockenden report and the AMOS review into maternity services, and there's lots of learning in both of those reports, and particularly in the Ockenden report from what I've read so far, in governance and safety and the kind of architecture of governance and how that's most effective. So we'll be taking that learning back into our teams and looking not only for maternity services but how we can apply that across the whole organisation, because there's some helpful learning and reflection on PSEV, for example, as a way of working, and so we'll be looking at to develop our own internal action plan more broadly around governance for the organisation, just to ensure that we carry through learning from those important reviews. So just in terms of this report, obviously we've discussed at board previously and we've discussed in other committees around a focus on making sure that we don't have overdue incidents that over a particular threshold. Those have come down over the course of time, and we're still working on making sure that we are closing incidents in a timely way. That's important because it's that double clicking process of making sure actions are complete and an incident can be confidently closed. I think we've said before at board that all of these incidents have been reviewed. So these are not incidents that have never been reviewed. These are incidents that have gone through a triage process where action has been taken, investigations may have been commenced, they may have been completed, but we haven't closed the loop administratively in terms of closing them down on the system, so they're showing as overdue. We are going to look, I've mentioned this previously, we've now developed a different dashboard for looking at different indicators so we can get a more rounded view of incident sort of data and performance. So for example, incident trend analysis and time to triage. So that will start coming through quality committee in the next committee round. This report details ongoing investigations, so level 1 investigations, and provides an update and details of those. Where we've got family involvement, which is obviously what we aim for under PSEF, we really want to have families involved in investigations, and where we don't, and some of the actions that we're currently looking to close. So there is a lot of work in terms of chasing up actions that are overdue, but those are tracked very closely, and as are our level 1 particularly inquiries, but also those high volume lower harm incidents, which are really important for us to look at from a QI perspective, as well as a safety perspective, to make sure that we've aligned our improvement work and we are doing preventative work as quickly as possible to stop any harm escalating in the organisation. I'm happy to take any questions, and Ian may also want to come in and give an overview.
Yeah, go ahead.
Thanks, Kate, and I look forward to the new dashboard. I think the penetration, the concentration required to penetrate the report is immense. But once you get into it, it's interesting. I think for me, the big question is, I think we've got really good reporting of what's happened. Where I think, and perhaps we can ask the Clinical Quality and Risk Committee to take this, is what I don't see is actions within the organisation about what are we doing to stop these happening again, and what are we doing to fix the incidents. I'm not sure it's a conversation to be had around the board table here, but I do think it's an action where the Quality Clinical Risk can get into saying, okay, well done, you've had X number of incidents in this area, so what? Are we just accepting that, or are we doing something about it? So I think that's and then that can go through QCLC and come back. Or
I think that's helpful, John. I think my question to Kate was almost going to be that it's the same thing, but the number of overdue incidents, and to repeat Kate's point, that doesn't mean those incidents haven't been reviewed at all, but the number of overdue incidents is coming down. What do you think's been the biggest factor in driving that, Kate?
I think it's quite a lot of work. It's work through the different teams, so through the central team and through the divisional teams, to really focus on areas that are overdue. Ian's had direct contact with clinical leads to make sure that people are aware that it's a requirement to close down these incidents and make sure that learning has happened and that actions are also closed. It's not just the process of just closing them on the system. We need to make sure that the appropriate work has been undertaken to embed learning and any change. I think where we've got very high volumes of incidents, so one of the positives of having a really high reporting culture, which we've got, so our incident reporting culture is very strong, is that we then have a lot of work to do at the other end of the process in making sure that incidents are followed through and tracked through to completion. We're looking at system issues as well. Can we make that easier and more straightforward on the system? Are we asking for people to follow too many different steps from an administrative perspective that aren't adding benefit from a safety perspective? So that we can make sure that energy and effort is being directed in the right places. So we'll look at that in terms of the radar system and the way that the forms, for example, and the workflows are constructed. But nevertheless, we know that compliance for us is a continued focus. It's a focus in every area of quality.
I think that leads to your point, because the and what isn't just about the and what learning from the actual incident, but it's the and what has made a difference to us as we travel looking through this. And we kind of need to hold that as well, so that we then maintain it as we travel forward.
I suppose it's interesting. I think we've had this conversation in part before. For me, overdue instance is a complete red herring because everything gets examined every day.
Yes.
For me, I mean, it's interesting. It's useful, but is it a useful factor for the board to determine whether the organisation is safe or not? Now, in my view, for me, does the report tell us that we're safe today? Yes, no, and does it tell the board whether we're getting better or not, or better or worse because of the actions that are being taken within the and neither of those elements, given the process that we have around reviewing every incident every day, has an impact on overdue. That's almost like a technical admin. Is that I want to know whether we're safe today and whether we're getting better or worse. And I think QCLC is a really good place to do that with better informed actions within the board.
I think those the actions is the important bit. I've got Gary then is.
So my point was very similar to Joe's actually, which is that we've seen a number of incidents with harm over the period since PSEP has been introduced. Appears to be on an upward trend. Some of that we've put down to improved reporting, but more people committed to the process. But what we don't know from this is whether we're actually getting better, whether we're learning or anything like that. I don't know what to make of this as a number. Is it good? Is it bad? Is it different incidences? Is it the same reoccurring? So
yeah, so spot on. And I'm sort of hoping, but I haven't checked with Kate. Nodding as I say this is good. So our organisation is growing. So in absolute terms, it's likely that our pressure also may go up.
Absolutely.
And that's not in any way ignoring any harm to patients. But what I'm interested in is per 100 bed days, per 1,000 bed days, what's going on? Are we getting better or worse?
So the other start I had, which I don't want to elongate, but given this is a national programme, are there comparisons we can draw from other hospitals? Was the other thing that may give us some assurance as to where we sit?
Yeah.
So the short answer to that would be no. So, but PSEP, the introduction of PSEP clearly means different things for sort of social scientists and statisticians, so there are different approaches sort of thing. There has been some peer-reviewed evaluation of PSEP published last month, so which I would dig out and have a look at in a second. So it's answering the same question.
Are we talking about two different things there? Sorry. So yes, absolutely, around research and the process and how that works. I thought you were referencing, have we got peer data on how we perform against pressure officers?
Yes.
Or any.
So I think we do have that sort of comparative data, absolutely. And again, I'm looking at the sort of dashboard that will come through, and we need to understand where we see it.
Yes.
So this is good. And I agree with Joe that once you start really trying to dig into it, it seems to be kind of useful things. It's only going to be helpful if it contributes to and increases our sort of learning culture about what we can learn from these incidents, because otherwise it's just blurred numbers. And looking at the women's health, where there are 10 overdue actions, and then it lists them all, some of them are kind of a year out of date. And I don't know whether this is just really going to look at some stuff and see whether we can learn from it, or the fact that in women's health, unlike other specialties, we've actually got 10 overdue actions where someone was going to do an audit, someone's going to look at some data and see what it said. Should we be worried by that, or is this sort of more procedural? Because it does, women's health one here does stick out in terms of number of overdue investigations compared with the others.
Hey, do you want to come in on that?
What do we draw from that?
So I think there is, so women's health, so number one, from a positive perspective, women's health are a very high reporter of incidents. So volume wise, they are a very high reporter. That I think, recognised everywhere as a positive indicator of culture. And so I think I agree with you. We don't want to have overdue actions. I mean, I'm not going to defend overdue actions. We put a date for an action to be delivered and it's not been delivered. And there's not the narrative in the report to support why. So I think that's, for us, is a focus in terms of supporting the division, that division particularly where we've got very high volumes, and it's similar in complaints, not in women's health, but in other areas where they are high, so emergency department, for example, where you have higher volume, making sure that the systems and processes are lean and effective and efficient enough to be able to be sustainable. So we don't have these sort of peaks and troughs over time, and that we are taking the learning and we're putting actions in place. This, I think, is probably no different in reality to the old serious incident process, where there are action plans and we tracked action plans and we track them differently. So PSERF is, everything is in this report. It's very transparent, which is really positive. But it also means that you're seeing all of the overdue things and not balanced with the things that have happened, the many learning events that have happened in the same period of time, for example, all of the actions that are complete. So my challenge to my team at the moment is to make sure that we're providing a balanced view, so that the board can have better assurance around safety, particularly. So we don't just present what's overdue in women's health. We present all the work that they've done in making in improvement, in actions being completed, and etc.
Thank you.
Thank you very much. Thank you, Kate. And I'll go to the maternity update from Ian.
Thank you. So I don't propose to go through the paper for the detail, the messages that ones we've looked at forward. The thing that is new is our HSMR, because the standard mortality ratio has now gone above the threshold, so we are, if it is higher than should be statistically. The shimmy, which has got parametric remains and the control limits. I've spoken lots in the past about various data reasons for that. I've now received a very long thesis from an expert on this going through. Pointing that we will have the in September. I am confident to report building assurance around it. So the data issue not taken. Save you out of the position. Positive side here, we've got a good reporting system to house all the information that the examiners and the mortality and mobility meetings go through. So we'll see much more visibility of that going forward. And Nicholas and I, as the Associate Medical Director of Mortality, we get committed to visiting each of those.
Yes, just building on what Ian said there, in terms of our medical examiners and the confidence that we have that they are in a position to find errors, find issues as they come up. Is it worth just having a minute on the board around what that looks like so people can understand it? But I've done that for some time.
Yeah, so medical examiners were introduced following murders committed by our ships to all types of face their response to that. We now have medical examiners who are a combination of our doctors, consultants, especially doctors, and also general practitioners who work on a sessional basis as medical examiners. They now review every death that happens in the hospital. There is a significant training program that says most students is a trained or practicing medical examiner. So there is a big training program. It's a fairly standardised approach, and I think one of the things they do is they do have concerns. They articulate those, and they also trigger something called structured judgment, which is then what's meant to happen back in the department that looks after the patient with objectivity. So it shouldn't be a condition called needing a person's care, but another condition, specialty. I think it's that second bit to make sure it's standardised and outcomes that are both appropriate for that patient, but also learning patients. That'd be the area of consequence. The corollary hospitals have certainly been very happy with the performance of the medical examiners in that system since its inception. It's been iterating, evolving to another.
I think it's showing in your approach to the actual demand taking, amazing. That might be a good to read through, but I think that's I think the board can take confidence that that's in the process. And as you say, we'll hear back from that. Thank you very much.
Sorry, so I'm suggesting quality risks.
Sorry, I should have said.
I just realised as soon as I said, thank you.
I shall move on then to item 10, maternity assurance group update.
Thank you. So there are a selection of papers, the cover sheets, and then 3 sort of escalation papers for the activities that happened since we last met. Those all the advisors should alert formatting. I think the things I'd like to highlight is firstly a refresher or reminder around the governance of the maternity and newly assurance group, because we had this in various different iterations. The formal position, because it was a group, not a building committee, also to quality and risk committee. Now, given quality and risk committee happens quarterly, and the board has ample time to hear about maternity as well, and it's a lot of time to do as well. Formally, in terms of quality, how many executives participate in various other things, it's working. As I said, there were three sets of sort of escalation summary notes on the maternity and the insurance group which they sat, and they met in April and June, covering data in February, March, and April. I think the key issues in those sheets, and we take questions in a moment, is that the unit has been pretty busy from that time, so that area. There's a notable status that's declared for the trust, we also have a notable status declared for maternity. Be happy to rates we're seeing on both major obstetric hemorrhage and also tears have increased slightly, dramatically increases, and there are improvement projects going on. Those certainly hemorrhage, part of it's very, very good at measuring sand volumes. Probably the most important thing I was going to talked about briefly at the seminar last month, which was the organisation unit triggered the maternity system, the new system that's been set up, triggered because of that case on it. Issue and we discussed this previously. 2 of those cases, that's where in many ways palliative. 10 deaths, 2 other cases, major reservation condition that's subject to having this. Attached to the papers here is the response that we was able to the critical safety check to the arson data also having triggered human rights assurance and so discussing alternative DNA insurance group and it did. Two issues identified in there was firstly the bed pressures. You're anticipating the next 3 or 4 weeks as we practice assessment to location that will preempt. We'll add some more back into the footprint good use for them. Second thing was the speed at which we're able to undertake cesarean sections. So there are various different categories, one comes up all in terms of a cesarean section, whether it's urgent or not. Category one, very urgent, should be done within 30 minutes, and we are very good at that mention. Category two, which is much larger volume, should ideally be 75 minutes for decisions for cesarean section. Sitting absent between 2/3 and 3/4 down. So we are paying attention in our theatre as with access. Apparently, we're not aware of it. So is over 70 hours.
Thank you. Really summary, Ian. Well, another one of the issues that we've been aware of related to workforce, particularly around community midwives, not having enough, and you may have read the home birth service was suspended 8 times in March. And I just wanted to highlight the fact that that's quite an important thing because part of the ACOS report and all the recent maternity reports highlight that there's an increasing, or there seems to be a significant group of women who prefer or who elect to have births outside of medical guidance. And that has lots of implications. Obviously for safety, that's what we're concerned about for the mother and the baby. But also when staff are involved, calls in at the last minute, the stress involved in being held somehow accountable for something that's been completely out with their control is quite significant. So I just think it's an important fact. So I probably conflated 2 issues there. I just wanted to bring a big picture as well because it is quite a stressful environment as we're all aware, and I think the staff at Milton Keynes do a really good job.
So when I was talking earlier about the 10 priority actions for the 100-day sprint, I did mention all 10. One of those 10 is for trust to review their home birth services. That's a general review in the meeting on Tuesday. Most trusts have done this anyway in October in response to suppression of future death sentences. But both home births and also the issue around care house births is much discussed in this.
It's too early to have dived into every page of the 300 odd, pages of the Ombudsman report of Baroness Amos as well. But one of the contributors to what happened in Nottingham was culture. And I just wondered it's quite hard to measure. You can look at patient feedback, there's sort of anecdotal stuff. But I wonder to what extent, as well as the hard data that you presented here very clearly, you try and look at, what some of the things being mentioned with midwives, like curiosity, midwife consultants, midwife nurse relationships, those kind of things, which are often a predictor of something's going to happen later. And I just wondered how you look at that and why you might do it in the future.
Thank you. So, fortuitously, around 2 or 3 weeks ago, we had General Medical Council and Nursing Delivery Council come in to deliver 4 seminars to work on. So, 4 different groups of multi-professional staff, and probably 70 or 80 staff total maternity attended those workshops. So the feedback from staff, so we got some good conversations going, sort of understanding each other's perspectives, and different pressures that may play through to the casual discussions. So that's part of it. That program was developed with trusts that were noted to be struggling with these cancer and others for the hours and that. And we invited that program to come in to make those own discussions to have. I think that probably it hasn't really been discussed as part of the 10-point plan and the day actions. I think potentially the maternity would be a really good place for audited peer review. Just as midwives, this trial at the units can come in and spend the day with and see and actually see all units that might be
I just want to make a comment here about the tools that one's going to use, which blended Bedford, Newton, Milton Keynes maternity matters. Just thought in terms of women were looking at that and using it. Really much the same.
Yes, so people may have seen this tool as you described, which strangely in this situation combined the performances of Bedford, the Luton Dunstable and ourselves under the old integrated care board structure, and is no longer obviously relevant now that we're part of Central East. It's the first time that that has been published, and it gives some, I think, well, some very clear variations in performance for our organisation. If you look at the BLMK level reporting. And so I would urge anybody that is wanting to understand how we performed as an organisation, that people look at the performance of our organisation and not of our organisation wrapped up in other maternity unit data, because it does lead to significant variation.
Any other questions on those issues? Thank you very much. I shall move us on to the integrated performance report. James, I think I might have seen you to ask here. And we're going to give a little bit of a context of just the information today, but also how we're going to perhaps track the conversation at board in terms of this in the future, or we're going to touch on that in the private meeting and that's that in September. Yes, that's fine. So I shall hand over to you for that. Thank you.
Thank you. So this is the performance report for the first month of the financial year. I wanted just to give some context on where performance went, focusing particularly on some of the waiting time standards, part of this, but I'll touch on a couple of other areas as well. Then some comments as well about where we're going in terms of trajectory. The overall message for April is, as an organisation, our performance on, particularly if I focus initially on the waiting time standards, slipped back slightly. The organisation should be really proud of the efforts, and at the end of the last financial year, going into March, it's really exceptional performance, improving planned waiting times, cancer, and the emergency time. But if you look at the individual metrics in April, they slipped back ever so slightly. There's context to that. If people cast their minds back, there was a period of industrial action around the Easter period. We as an organisation are resolving our contract in terms of the amount of activity we can plan to do without that. And that means we're doing less activity in April while we work that through than we were doing in March. And it was a particularly high period of demand for our emergency department. Just comparing to the previous year, on some week, we were sort of averaging an extra 20 patients a day compared to the previous year coming through our main emergency department, which is a real jump. But at the same time, our admissions were very similar in terms of profile to the previous year. So it is other people walking into the department. Going through some of those particular standards, the emergency department as a whole, and that's sustained pressure, particularly impacting it, was 70.1%. Just I'm going to note as I go through where we had also said we'd be on plan. So that is an area that we had said on plan we'd be at 78%. I shared some of their contacts. That's an area I'll come back to, but our steps to start improving it and recovering to the really good performance in March. Our referral treatment time under 18 weeks was 61%. 61.3, which was slightly ahead of where we said would be on plan for 61%. That has slipped back slightly from March. Our diagnostics, what we call the DMO1 in the parlance, has slipped back 76.8 compared to 82% from March. And our cancer standards, the one in the pack, is our master diagnosis standards, around 28 days, if people are diagnosis or not. That was 75%, which was about on plan. I'll note by the end of the year, we need to be improving that towards 80%, so we average that over the year. Our 62-day standard, which is starting treatment, 65%, where we were in April against a planned target of 69. So there was work to do on all of those, wrapped up in some of those challenges we faced. On some of the other areas, I think just a couple to call out. One is, we have started the year well on some financial delivery and identifying the efficiencies. That is important as we keep grip on the organisation, because we can focus on really improving performance and investing in performance, as long as we're addressing waste and efficiencies elsewhere in the organisation. So our financial control is important to sustain. Money and quality are two sides of the same coin. Doing things right first time costs less. So good quality leads to performance, leads to money in the right place. And we need to be focusing on that. But money is a signal we're managing that sequence. And then if looking within the pack, pressure ulcers, if I just call out, slip back ever so slightly, we've touched on it in quality, but looking at some of this around as we transform our services, actually fewer people needing to come into our organisation, as fewer people might have the opportunity to get a pressure ulcer. As we work with our partners as well, areas like length of stay and reducing our length of stay, again, reduces the risk of pressure ulcers and that harm it can cause for patients. Just looking ahead, one of the things sort of coming in, to notice, calling out to slip back slightly, and the fantastic performance in March, slipping back slightly, talks to an organisation that can do really, really well and pull together. But our question now, how we look into the future, how we have some more of the transformation is going to be less sustained performance improvement. Some of that work together, so it's not just exceptional efforts at different peaks. And when I look at comparisons to peers in terms of how we're performing, there are high spots in there, but there are certainly places we are looking at already where we can learn from new models that are brought in, improvements. If we look locally, someone like West Herts, the emergency department performance is at least 10% higher for patients coming through every single day. So we're speaking to them and learning from others up in Lincolnshire and others who have really improved about how we can put some of that together. Looking forward at some of the other aspects in there, particularly on the planned waiting time, areas that started in April, but we're not seeing really hit through into the numbers of performance for patients who already benefits. And started a new straight to test pathway for our urology patients. That's an area that has impacted our faster diagnosis standard. We're already seeing improved performance in that area. Straight to test is when patients, rather than needing that patient appointment first and then needing to be sent for a diagnostic and then coming back for a review, we're changing the pathway and redesigning that so patients can be seen with the diagnostics they need first. That helps them often get resolved, particularly when it's benign and non-cancerous straight away, rather than needing to come in and is more convenient as well as faster for them. We've also got innovations going on elsewhere in the organisation. You might have seen some of the public social media around our clinical letters AI that will help our outpatients areas. And I've touched on some of the learning by our minister team looking at trying new things to help us with some of that. So it gives a bit of an overview, particularly focused on some of our performance and waiting time. Behind all of those numbers are patients who have waited longer than we would like, and the impact on the quality. So it's that work together to have the right quality of care, linked to performance, and support
data that we're virtually in July. Is that? Do you think there could be any more immediacy of reporting, or is this going to be quite a time frame review?
If I could be given time to resolve that answer, because this is exactly 1 month since I've joined. I come from an organisation that and I've worked in other organisations where this pattern is similar, that by the time you go from a month closing through the validation, through the referral and review and sign, it comes to the board. I know this is April, but actually, so that timing is not completely out of line. That said, we all have access to information that's published more frequently, so it's how we can think about joining some of that.
The question is the thresholds, which we know are understanding in terms of the financial thresholds and waiting for a contract to implement that. But there are some thresholds which are measures that we have tracking through. I suppose I'm asking a question of whether the board will see the threshold measures put onto the IPI.
Yeah, we will wait so that what Heidi's referring to here, if people look very closely at papers, if you look at the standards on here, the to be confirms that fall down there, those will be in the next IPR. We will wait in resolving some of the contracts, some of the other updates part of it. Because we have some standards, we have our activity plan. It's also some of the trajectory in the meantime against those standards that we just proposed.
But thanks for that. And I think Heidi is spot on here. That's what we say, 2nd of July, we're looking at April. The one that worries me is ED. Clearly there were some factors in April that you've talked about, industrial and so on. But throughout last financial year, we were sort of pretty much there or thereabouts in terms of what we'd set ourselves. And there's a 10% drop in it. So I just wondered if you've got any intel on how that's going, even if it's anecdotal, how you think it's going, or what you might have heard, because obviously you weren't here.
Yes, so I wasn't here, but
We just have to wait until we get next month's worth of data, because that's the one that's moved quite a lot. And I don't know, again, it's a blip of industrial action, or actually, we're seeing more people who can't. Yeah.
So ED has been on sustained and high pressure. There is, if you look at our activities compared to previous years, a step change that I remember when I was being interviewed back in February and doing my study on the numbers, people were talking about 300 being a busy day.
Yeah.
It feels like a quiet day the last couple of months. So there's been a step change in attendances that are coming through. That is an area to dig through. There is also things in our gift that we can work in terms of the process, the setup, how we're working. That activity and change that is somewhat again. We're looking ahead to pilot and try different things and team design.
So
Yeah, it's not, I should say as well, it's not just the emergency department. The emergency performance is a signal on the whole organisation. So one of our talking about transformation, that's sustained improvement, the areas of priority are around our flow, around our outpatient model, because it has such an impact on a number of our planned care pathways, and then around partnership with others.
So mine's a similar point to when I raised the last one, which is the lenses we put on things and how we pull the data in to get a holistic view of something such as patient safety. And there are obviously some measures that are on patient safety, but we don't necessarily group them all together or look at them in an holistic way. For example, looking ahead to the workforce update, looking at staffing levels, looking at medications, looking at red flags. So it's not a specific question. I've just got this repeat question, which is, are we looking, if we're looking at safety in a different way under the nursing workforce update? There's other measures in there that obviously are being zoomed in on to say, are we safe, that aren't appearing on the integrated performance report. So I just asked the question, what should we be looking at? Is that making any sense?
Marsha and I are smiling at each other because we had a conversation earlier on this morning about the definition of sort of safety in the nursing staff levels. And it's a conversation we've had more broadly as execs. I think you're absolutely right in terms of wanting to triangulate this. And if I could press pause on that a little bit until we get to the nursing safe staff, Marsha will come in on that, and you'll see where our thinking is going around. Are we just reporting things, or are we trying to triangulate what's going on?
That's exactly the question.
I think it's interesting on the board acknowledge that it's good that we have that conversation and we'll talk about it more a bit later. And we'll be coming back to that probably for the September meetings, how that conversation developed. But I'll go over to Sarah.
Thank you. Two questions, if I may. One, what do you think the pros and cons of receiving maternity data in the IPR might be? I know potentially confusing because we have logs, but gives a holistic picture. And the second was around pressure ulcers and the response to the medical device representatives and the incontinence management. Do you have a trajectory for improvement there, or just a one-off?
Yes, there is a planned trajectory, and the reason why we have targeted those things is because we've seen high incidence of device-related ulcers within like ICU setting, respiratory wards, because of the devices that patients use. For us to develop CAT2 or CAT3, because people who have incontinence issues, they come in, they use pads. So it's about how we start to do that early intervention. So for example, Ward 25, if I get into granular details, we started a pilot there where rather to support patients mobilizing to the toilet earlier, so they're not, using the products that they may have to use. So it's those kind of work that we're underway. The other positive is that there's been further investment into the tissue viability team with an increase of champions. So it means that we're having a wider reach within the organization to upskill staff, and then that closer monitoring to be able to demonstrate assurance and compliance on the improvement work on the way.
And you think I will be as well in terms of hospital acquired the measurements. The or SDEC and ambulance on those, that's an important part of that in terms of data capture. I'm assuming, again, so I presume we'll be looking at that, to make sure we are capturing that at the right point in time. That be
Yes, historically, the issue, one of the main issues in this area will be Alzheimer's high pressure that is already present.
Yes.
So yes, we've got better at that really too.
Yes, because what we've noticed for the past year, the frailty, the demographics, the pressure ulcers that are coming through from the community, they're quite complex. So if they came in at a 3, and at the time when we assess them at a 3, because of we may not have done the debridement or whatever, it could have been presenting as a 4. So when it becomes a 4, it's attributed to us, but may not have been. So it's those work. So what we're now doing is working closely with CNWL. So we're starting to flag those, having a better understanding of the patients that are coming in, and actually shifting our threshold in raising section 42s, because we tend to be very good at raising them against ourselves, but not really flagging when the patients have come in quite a complex deteriorating state.
So just on that, I both what Marsh said, also what I said. In terms of identifying pressure ulcers, of course, it's important to choose the right organisation. In fact, I'm not that interested in that much. It's time and waste.
I'm still going to change. But being with the Washington, in the IPR. Well, actually, we'll come back to that.
I think that there's an industry national association
Yes,
to work out A, what that's going to look like going forward, and B, that would.
Excellent. Okay, so we're at okay time. I knew it takes slightly longer on that part of the agenda against the agenda times. So we're going to have a short 10-minute break, and we will come back at just before 25 past. Those people online are having a short break, back just before 25 past. So